So this is showing, it's called a scleral buckle. This is the surgical management, and this is where that kind of buckle or strap, if you will hold the retina and choroid together with an implantable and circulating strap or buckle. So that's how it gets the scleral buckle name. Looks kind of like a belt. Macular degeneration is another very common cause of visual loss in patients over the age of 50. And so, basically you have glaucoma, cataracts, and macular degeneration, all three very common age-related visual disturbances that are all progressive. One thing that is a much more significant risk factor for macular degeneration is smoking. Smoking quadruples the chances that somebody will develop macular degeneration, and macular degeneration does definitely progress faster in people that continue to smoke as well. So again, this is a progressive and one of the leading causes of blindness. The macula is the center of the retina, which normally receives light from the center of the visual field, and we need that light for detailed vision. So what happens with macular degeneration is they lose more of their central vision first. The peripheral vision can stay intact, but they have loss of central vision. So I like this picture because you can see kind of how it would look to the person with macular degeneration. And this is really important to be sensitive if we're taking care of older people that have macular degeneration. We have to understand that they can kind of see us there, but they can just kind of see shadows of us. They can see the outline, but they can't necessarily see all of the details. I know my grandma had progressive macular degeneration, and she would be, more going off of our voices, and obviously she could see enough of us to know who it was for most of her life, but definitely had progressive loss of vision where it wasn't as quick and easy, and we had to make sure that we, talked at the same time, and that helped with her to identify. So loss of central vision, if you're there looking, they can see appearance of pale yellow spots on the macula. They also can have different visual distortions, so straight lines could appear wavy, and again, difficulty with activities that require focused and closed vision. So with macular degeneration in elderly, very difficult for them to do maybe some of their needlework, knitting, reading, things like that that need that very close and focused, detailed vision. So for management of macular degeneration, again, it's primarily quality of life and educational. There's no medications available for the treatment, so it's all of the safety measures, preventing injury, all of the home safety evaluation and talking with families and everything to hopefully have them be able to stay in their own home and do the things that they want and need to do while staying safe. Because as you can imagine, cooking, any of the psychosocial or relaxation type activities, they'll need to have modifications. They do want to have annual eye exams, and they can monitor the disease progression, and they'll also be able to basically self-monitor their progression because they'll know how much vision is being lost on their own without even any testing. Large print books, audio books, brighter lights, magnifying devices. You may have seen big magnifying glasses in patients' room at nursing homes, and bright lights. They have some really nice setups now that can help them to be able to continue to do some of their close vision activities for a longer period of time. There is some research that photodynamic therapy can slow the progression of macular degeneration. There's a light sensitive dye that it's injected into the defective vessels, and kind of like a laser activates the dye, which can help with that. There is also research on antioxidants, so it doesn't hurt for them to increase their diet of antioxidants or to take some supplements that have antioxidants in them to possibly slow the progression. And if for some reason they're still smoking, they need to for sure quit smoking, because that is certainly going to increase the progression of the macular degeneration. So some general guidelines for interacting with patients who have a visual impairment or who are blind. I mean, most of this is pretty straightforward. You've had contact with patients and even, maybe family members. So I think the biggest things is just, don't talk louder. They can hear still, or maybe they are hard of hearing and also have bad vision. But either way, sometimes we have a tendency just to raise our voices with elderly in general, just assuming that they can't hear us. And again, sometimes patients that can't see very well are sensitive to that because they kind of know what you're doing, and that may irritate them a little bit. So making sure that you're just mindful of that, making sure you're identifying yourself as you approach them, that you identify yourself before you do any touching, and again, making sure they hear you and know that you are there and present. As far as delivering food trays, we can use like the clock for cues to say, your corn is at 3 o'clock, your bread is at 6 o'clock, your milk is at 12 o'clock, or what have you. Making sure you turn the bright lights on. So even, you have that overhead light in the hospital rooms that we typically turn on for procedures or dressing changes or catheterizations. That's a really great idea to turn that light on for most older people, even if they don't have a significant visual impairment. If you do that, many of them will be like, oh my gosh, wow, I can see so much better. So that's also something to keep in mind. Of course, keeping the room free of clutter and all of those safety precautions, making sure that they are asking for assistance and that you are helping them to move and helping them around that environment. And especially when they come into the hospital, it's all different. They get very skilled at working in their own environment that they know, but if they have a transition to a different facility or a different place for a short time or long time, we need to help them with that transition. Ocular trauma. The most common causes of ocular trauma are listed here. Occupational injuries, maybe in the workshop, or you have your contractors, construction workers that may get wood or metal or fragments of something in their eye. Sports, certainly, sticks, hockey sticks, pucks, there's all sorts of different things, equipment and things that could be a safety issue as far as sports, weapons, assaults, war, motor vehicle accidents, so all of those are pretty obvious as well. So we want to know most of what we want to do with ocular trauma is all of the preventative teaching to prevent injuries in any of these areas where people are at higher risk. So here are some examples of the preventative teaching. I don't have every single thing listed, but you can kind of see making sure that you're spraying the nozzles directed away from you before you press down, making sure that people are wearing safety glasses in the workshop. As far as kids and children, some of the toys are definitely potential risk to their eyes. So dart guns and pellet guns and things like that, they should be wearing safety glasses for that. Lawn mowing, as far as branches that are hanging low that could poke in your eye, or rocks or stones or things that could fly out of the side of the lawnmower. Goggles, like I said, safety glasses, helmets for sports, safety equipment that people wear with sports. And then, of course, fireworks. We talked about that. Never allow children to ignite fireworks, and even adults need to be safe, not drinking alcohol or using chemicals while you're doing fireworks celebration, and just making sure that everybody is not too close and all of those sorts of things. So initial interventions for a couple different eye traumas that would be most common, chemical or foreign body. So for chemical, there has to be irrigation of the eye with normal saline or plain tap water, whatever's available. If it's in an occupational setting, there's likely going to be the ice water, the stations to be flushing the eye. The patient needs to be in the supine position. The head needs to be toward the affected eye. Obviously, we wouldn't want to flush towards the unaffected eye and then have affected chemical get in the second eye. So obviously have it, their affected side, it will be dependent. So if it's the right eye, they will have their head tipped to the right so that we're flushing from the inner canthus to the outer canthus. Foreign body, there should be absolutely no attempt to remove the foreign body, although you'll see people that are trying hard to get whatever out. That can further put it back further and cause more damage. So we should instruct patients to basically protect their eye or cover their eye with a shield, or if they have just a paper cuff or anything that they can do to get it covered, and then they will need to come in to be evaluated. I mean, for either of these, once you do that initial first aid, side, they need to be seen to have an eye doctor or emergency room physician help with that in emergency care. So this picture just shows you that shielding that should happen, and again, you make it creative with what you have available. And then the flushing, making sure that you're flushing from the inner canthus to the outer and that you are not flushing into the other eye. Conjunctivitis, otherwise known as pink eye, is where you'll have inflammation of the conjunctiva. This can be either viral or bacterial, and it's highly contagious. You will see an obvious pink-red appearance. The patient will feel a kind of foreign body, scratchy, itchy, very itchy sensation. Could be both eyes or just one eye. And also they'll have a lot of mattery in their eyes in the morning. Sometimes it's matted shut and crusted over. And again, it's very contagious and spread by hand contact. Management involves obviously good hand washing, medicated eye drops, typically cannot return to work or school until they've been on those eye drops for 24 hours. A person should not share towels, linens, makeup, toys, any of that makeup or other things that could be contaminated should be discarded. And sometimes for comfort, just a cold compress can be helpful. The correct answer here is 1. We know that glaucoma is a progressive disorder, not curable, and vision that is lost permanently. But with good compliance, they can, delay the changes and slow down progression. This answer is 4. The patient needs to be on bed rest with the eyes patched, and then the dependent eye needs to be down. So with it being, if it's the left eye, they would be dependent on the left side. The correct answer here is pain. 1, 2, and 3 are all normal sensations after cataract surgery, but they should not experience pain, severe pain, or nausea. The correct answer here is B. We know that aspirin disrupts platelet aggregation, and there will be more risk of bleeding. The correct answer here is C, because the question's talking about glaucoma and use of medications. Really, the knowledge of making sure they know what to use and using their eye drops and taking them consistently for lifelong therapy is a priority. The correct answer here is B. We need to make sure we flush from the inner canthus to the outer canthus if there is a contaminated eye. The last portion is just going to be looking at the ear and a few ear conditions. We know that the ear is a sensory organ with dual functions, both hearing and balance. So again, this is just a little bit of the A and P, so you can see that there's the external ear components, the middle ear components, and then the inner ear components. There are 2 pathways for hearing, both air and bone conduction. So with air conduction, the sounds travel over air and fill the external and middle ear through vibration of the tympanic membrane. Through the bone pathway, the sound travels directly to the inner ear and by bone conduction and bypasses the tympanic membrane. As far as balance and equilibrium, these areas send their information about equilibrium and balance to the brain, the cerebellar system, for coordination and perception in the cerebral cortex. So if somebody has an inner ear infection or is having trouble with their ear, we always want to be thinking about their balance and equilibrium might be off, and this could also be a big safety issue. As far as assessment, when we're doing a head-to-toe assessment, we're basically just kind of inspecting the external ear canal, mainly looking if we see a lot of wax or impaction that way. We're doing our assessment, of course, as far as their hearing, if they're hard of hearing, if they have hearing aids, etc. In a hospital setting or even nursing home, you're rarely going to be using an otoscope, but if you're working as an advanced practice nurse someday, you would be. With the otoscope, if we are looking or assisting the physician with that, you will pull the ear up and back for an adult or older child, and down and back for less than 3. I just think younger, down and back. So that's going to be the best way to kind of straighten that ear canal to be able to visualize through the otoscope. As far as evaluation of the gross auditory acuity, we have several tests. The whisper test, you'll test one ear at a time, and you whisper softly 1 to 2 feet away and see if they can hear. So just whisper numbers or a statement and ask the client to repeat that. As far as the Weber test, this is testing, assessing bone conduction of sound. So you'll place the conduction tuning fork on the patient's head or forehead after you have set the tuning fork in motion. So you'll hold it firmly and then you'll basically set that in motion, and normal hearing, they should hear the sounds equally in both ears. The Rinne test tests for both air and bone conduction, and this is where you assess both air and bone conduction by setting the tuning fork in motion just outside their ear, as you can see in that picture on the top right, and then also you set the tuning fork on the mastoid bone. So again, these aren't things we're doing routinely, but if you're working in a specialty area, you may be assessing for evaluation of their conduction, bone or air conduction. Important things that we will assess on the health assessment is to really look at what sorts of signs or symptoms do they have of hearing loss. We know that especially in infants, toddlers, young children, as they're learning for speech development, if they have developmental delay in their speech, we always would want to question if they're actually hearing. I want you to take your hands and put them over your ears and then talk and say some words. The sounds, the pronunciation, the intonation, all of that is not clear. So if you can imagine that you're just learning words for the first time, such as a young child's developing speech, that could be very difficult. So it could sound, their speech can be delayed or garbled or not pronunciating the sounds because they can't hear all of them clearly. Also, in the elderly population or other ages, you might see more of a change in attitude or social withdrawal. So some of those things may not be that they're purposely acting up or maybe even not depressed or anything, but they just avoid social situations because it gets frustrating because they can't hear or they can't contribute to the conversation. Again, as far as pediatric considerations, just know that there are oftentimes with either vision or hearing changes in young children, school-age children that are not identified. They may have delay in their school progress or social or academic development because of their limitations. So it's very treatable and we can get them help. So we want to identify people as soon as possible. As far as risk factors for hearing loss, you can see there is the possibility of family or genetic or congenital malformation. Low birth weight babies are more likely to have hearing deficits. Use of ototoxic medications, and we'll get to some of those, but furosemide and aminoglycoside antibiotics are a couple of the categories that we've talked about so far that are more common medications that we need to understand are toxic to the ear if given too fast or with too high of concentration. Recurrent ear infections is a big red flag, chronic exposure to loud noises. So we see a lot of occupational hearing loss, such as farmers, road construction workers that are around a lot of heavy equipment and sounds. So communicating with the hearing impaired patient, hopefully you've all had some exposure of talking and working with patients that are hard of hearing. Some very fundamental things, but very important, is just to make sure that you're not coming from the side, that you're coming straight on, that they see you visually because they may not hear you, that you speak clearly and slowly, that you try to actually even enunciate more religiously and just even more deliberately because they might be reading your lips. Move closer to the better hearing ear. If they identify that they can't hear well out of this ear, well then obviously you're going to speak in the other ear. Do not shout. It's better to get closer to their ear and talk loud and pronunciate that way. Again, a quiet room, less distractions, noise. You can also use hand gestures to try to get your point across if you're having difficulty communicating, no different than if there was a language barrier. And then really important to make sure if they do have hearing aids that they are there and that they are functional. Safety measures for ear infections and trauma, we have some of them listed. Not, using small objects in the ear, making sure that, we're washing our hands, and if we are, kind of carefully cleaning out that external ear to make sure we get it dry. Other things, if they've certainly had any ear type of surgery, they want to make sure they're sneezing with their mouth open, blowing the nose gently. The biggest things is the repetitive loud noises. So a lot of safety OSHA regulations in different jobs and occupations and factory workers and things where we have to make sure that we're having the appropriate ear protection while we're doing those sorts of jobs. Also the, work, just machinery or woodworking, things like that, even for hobbies. Certainly guns and hunting, certainly super important if you're going out and doing, sighting in your rifle, deer hunting, any of that, important to have ear protection. And then, we might see some changes here with some future generations here with how everybody's plugged into iPods and things like that. So are we going to see more hearing loss in this younger age group as they get older? We'll, yet to see that, but it is a possibility. I have listed a few of the gerontological considerations or expected age-related changes. Cerumen is the formal word for wax. So the wax definitely becomes harder and drier. There's increased chance of impaction, which can definitely affect their hearing ability if it's packed full of wax. There is degeneration of the cochlear cells, and that's the main organ for hearing. So that is, there's just a normal age-related loss of hearing. Again, lifelong exposure to loud noises. All of this exposure, just like skin exposure, is, cumulative. So is exposure to noises as far as how it's affecting our hearing. And then ototoxic medications, again, they may have been exposed to more ototoxic medications that we'll be watching out for. Some of the most common ototoxic medications are listed. With diuretics, I want to clarify that not all diuretics are ototoxic, but your furosemide, your Lasix, and then your Diamox, both of those are ototoxic. There are several different chemotherapy agents that are ototoxic, such as cisplatin, vincristine, anti-malarial medications. You may have heard of chloroquine. Anti-inflammatory agents such as naproxen or Aleve, ibuprofen, your regular aspirin. So that's kind of a big category that we see. And then the aminoglycoside antibiotics as well. Those are both nephrotoxic and ototoxic, as are the NSAIDs. So both the NSAIDs and the aminoglycosides, we just learned them to be both nephrotoxic and ototoxic. Now, one of the big things with these ototoxic medications, most all of them have to do with how much we're taking of them, but then also could be the rate of administration. So furosemide, very important to give it at the safe rate. 10 milligrams per minute is going to be the slowest recommended rate. It does go up to 20 milligrams per minute, but I always say keep it simple, 10 milligrams per minute. So if I'm given 40 milligrams, I push it over 4 minutes. 2 to 4 minutes would be technically correct per the drug book. Now, if you push it too fast, they can get ringing in the ears, and they can have permanent hearing loss. So we certainly don't want to be on the end of producing permanent hearing loss for someone that's been hospitalized on, say, furosemide or vancomycin. So acute otitis media is one of the ear conditions that we're going to talk about because it's very common, and especially in infants and children, to have ear infection. So this is an infection or inflammation of that middle ear, often a consequence or secondary to an upper respiratory infection, or even can be secondary to like a viral influenza. So again, like I said, increased incidence in infants and children. They have more exposure to germs like at daycares and preschools schools and elementary schools, but also infants and children have shorter eustachian tubes, which impacts that ability to get infected as well. As far as symptoms, earache, ear pressure, but again, you want to always relate it to infants and children. Maybe they're just pulling on their ears, they're not able to talk to you or say words, but you see them kind of pulling on their ears. They're running a fever, they're very tired or more lethargic or don't have the same energy that they normally would have if they were a toddler. May have associated dizziness, vertigo, nausea, vomiting. Again, that's pretty tough to identify in an infant or a child, but certainly if you get an ear infection more as an adult or later on, many times we'll have that inner ear kind of dizziness that can also produce that nausea feeling. So headache, ringing in the ears, again for infants, head rolling, pulling at their ears, crying, irritability. And if they look with an otoscope, they will see that red bulging tympanic membrane. So management of otitis media, certainly antibiotics, not going to review all those, but everything is fair game. We reviewed a lot of different antibiotics throughout the year with urinary tract infections and other areas of body systems, but you'll definitely see the need for antibiotics. Antihistamines might be needed or other nasal decongestions if there's allergies that are also contributing or happening concurrently with the ear infection. If they have chronic ear infections or chronic fluid in the inner ear, my son didn't have chronic ear infections but had chronic fluid in the inner ear that basically just turned to like glue. It becomes a very thick, hard material that basically just plugs up that inner ear and middle ear area. So ventilatory tubes or PE tubes, pressure equalization tubes, or you may have heard of T-tubes, tympanostomy tube. Those are all the tubes referring to a small tube that's inserted into the eardrum, and they are used to keep that middle ear aerated for a prolonged period of time. Prevents accumulation of fluid in that middle ear to prevent infection and prevent hearing problems. And usually they stay in for approximately 6 to 12 months and then they will fall out on their own. Complications of ear infection, well, they can develop chronic otitis media. They can have residual hearing loss if they've had several ear infections. They could perforate their tympanic membrane, and the worst case, they could develop like a mastoiditis or a meningitis. Motion sickness is a disturbance of the equilibrium caused by constant motion. So some people get motion sickness with planes, ships, cruises, or cars. Everybody has kind of varying degrees of that, but if you do have motion sickness, you will notice definite sweating, pallor, nausea, vomiting, or vertigo, and again, any degree of those from very mild to very severe. But if you're having that, there are some various over-the-counter medications that persons normally just take ahead of time because they know that they're going to have that reaction, or certainly don't do any other activities while riding in a car, such as reading or looking on their phones, or even some people have a better luck with riding in the front seat of the car. So again, there's just different ways and patients will be able to identify what works or doesn't work for them. Meniere's disease is an abnormal inner ear fluid balance. It's caused by malabsorption of the drain fluid in that area. There's increased pressure and can also rupture that inner ear membrane. So Meniere's disease, typically the biggest thing with Meniere's disease is that you'll see pretty significant tinnitus or tinnitus, the ringing in the ears, the vertigo, nausea, vomiting, headaches. Again, can have fluctuations in severity of symptoms, but they have pretty significant continual dizziness and vertigo that really affects safety or can affect safety and driving or injury, risk of falling, etc. So there are various things that we can do for that, but they can have a more serious form of that Meniere's disease or more serious symptoms that we need to treat. When you read on Meniere's disease, one of the biggest things that they talk about is drinking lots of water, avoiding caffeine, limiting alcohol, avoiding MSG, the monosodium glutamate, which is, artificial, like in like Chinese. I know it's very high, but it's in lots of other types of foods. Not smoking. The salt-free diet that's listed first, that helps to regulate the fluid balance in the middle ear. Remember that water is going to follow salt. So if we have more salt, there's going to be more fluid in that area that we don't want to be there. So salt-free diet, limiting, and avoiding caffeine, alcohol, MSG, not smoking. And again, usually the patient with some of the medications, the anti-vertigo medication that you're probably familiar with is meclizine. So if you see somebody on meclizine, that's probably for like a chronic vertigo, which may or may not be caused from Meniere's disease, but that would be what you would most likely see it for. Labyrinthitis is a problem with the inner ear, significant inflammation that could be either bacterial or viral. The patient will have sudden onset of very incapacitating vertigo and nausea, vomiting. So some of the symptoms are quite similar with Meniere's disease as far as the vertigo, nausea, vomiting. So again, depending on if it's bacterial or viral, will depend on what will work. If it's bacterial, they can take antibiotics. If it's viral, they really can't do much other than treat the symptoms. Fluid flushing, antiemetics, anti-vertigo medications such as the meclizine that we talked about will all be possible medications to kind of help treat that problem. So we don't see a lot of eardrops ordered, but if you are instilling rather eardrops, we're going to do all of our rights just the same, checking the med labels, dosage, expiration, etc. It's not a bad idea depending. We want the eardrops at room temperature, but you also could warm them, like put them just in a cup or a bowl with some warm water and have them get a little bit warmer. Wash your hands, of course, wearing gloves, and then again, tilting the head in the opposite direction of the affected ear because we want that affected ear to be up. Placing that drop in the ear then, and then typically they'll want the patient just to kind of gently tilt their head back and forth about 4 or 5 times, but then also initially just kind of keeping that head tilted in that direction so that the drop doesn't just run right back out of the ear. May or may not put a cotton ball in. You wouldn't want to do that right away because you don't want the eardrop to just absorb into the cotton ball, but it is possible that you could put a cotton ball in afterwards, or they can just stay on that side for 4 or 5 minutes, and that would be fine too. So this is a nice visual of just showing you, how to position the patient and how to, pull on the earlobe out and up, usually to straighten that auditory tube, to not touch the ear canal with the dropper, same as the eye, and then just to kind of, like I said, leave that opposite side or the side that you put the drop in upright for a couple minutes so that it doesn't run out. There are several different key points that are really important for the nurse to know as far as helping a patient recover from ear surgery. So many of them is you just don't want to increase pressure in that ear canal. So some of them very similar to increasing intraocular pressure, not exactly the same, but some of them do overlap. So avoiding straining for a BM. Some of the other ones very specific for the ear, not drinking through a straw, avoiding air travel where you're going to have that change in altitude, avoiding excess coughing. If you're blowing your nose, make sure you're blowing gently without occluding either nostril and keeping your mouth open. Avoid getting the head wet, washing the hair or showering for 1 week. There'll be a time frame there if you've had ear surgery. And again, just mainly keeping that ear dry, that ear canal dry for 6 weeks or whatever is indicated by the doctor. They may have you wear cotton balls. Want you to avoid that rapid head moving, bouncing, bending, and any of that kind of motion of the ear. So real vigorous activity or exercise would probably be contraindicated for a little bit of time. And then as far as what to report, mainly just if there's excessive drainage that you are noticing, you would report that immediately. So the correct answer here is 4. You'll put that on the mastoid bone to check for that bone conduction. So if somebody's having an acute exacerbation or attack of their Meniere's disease, we're really concerned about that vertigo and dizziness. So number one, risk for injury is the correct answer there. So what is acceptable? Well, talking is acceptable. The other ones are ones that we want to try to avoid the sneezing. We're not going to be doing push-ups or other activities that could really add pressure. It's not that we can't blow our nose, but blowing the nose, we don't need to do it very gently, making sure our mouth is open. So clearly here, talking is the acceptable and correct answer. This one, the correct answer is D. A lot of the times if that tympanic membrane has ruptured or perforated, that relieves the middle ear pressure, and so they have a sudden decrease in the ear pain.